Dear colleagues, today I am presenting the case of a patient who came to us during the 15th week of pregnancy with a suspected diagnosis of gastroschisis. From these detailed sagittal ultrasound scan images, you can actually observe the presence of a defect in the abdominal wall involving the umbilical ring, as well as the herniation of internal abdominal visceral organs, which, however, appear to be covered by peritoneum and amnion. Therefore, a clinical diagnosis of omphalocele was made, which is a congenital defect of the abdominal wall that causes herniation of abdominal viscera through the umbilical ring. But these organs appear to be covered by a protective sac made up of peritoneum and amnion. This condition is due to the developmental failure of the intestinal loops to return to the abdomen during embryonic development, with an incidence of approximately 1 case in every 4,000 to 6,000 live births. The contents of the omphalocele can then consist of the intestine, the small intestine, as in this specific case, the colon, the liver, especially in larger clinical forms, which therefore have a significantly less favorable prognosis, the stomach, and more rarely the spleen. The defect was therefore carefully studied in various detailed ultrasound scans. Also, in order to determine exactly what the specific contents of the herniation were, as this is widely known to be one of the main prognostic factors for the patient. Note from these sagittal scans how, within the omphalocele, the presence of slightly hyperechoic intestinal loops is clearly visible, which seem to be attributable exclusively to the small intestine. While in the sagittal scans we now see the rest of the abdominal viscera appear to be in their normal place, particularly the liver and the stomach. An attempt was then made to determine the maximum diameter of the mass, which is shown in this measurement to be about 12 mm by 10 mm. Therefore, the prognosis of omphalocele mainly depends on whether or not it is associated with chromosomal abnormalities, which are linked to this condition in up to 50 to 70% of cases. In order of frequency, trisomy 13, 18, and 21 are most common, while among the structural anomalies most frequently associated with this condition, with this abdominal wall defect, we find congenital heart diseases, neural tube defects, and urogenital anomalies. The syndromic condition most frequently associated with omphalocele is Beckwith-Wiedemann syndrome, which, however, presents other ultrasound signs that were not observed in the fetus under examination, such as macroglossia, macrosomia, and possible postnatal complications like hypoglycemia. Another malformative condition that should be considered in the differential diagnosis is gastroschisis. However, in the case of gastroschisis, the abdominal wall defect is located in the para-umbilical region, not within the umbilical ring, and more frequently on the right side of the abdomen. In this case, the herniated viscera are not covered by any membrane. Given the high association with genetic syndromic conditions, a thorough study of the remaining fetal anatomy was performed. Here you can carefully observe the cranial end, which was found to be normal, and particular attention was also paid to the oral region of the facial mass, in order to completely rule out the possibility of conditions such as macroglossia. In this specific clinical case now, you can very clearly see the distinctive tip of the fetal nose, the upper and lower lips, and the prominent chin. The lips are firmly closed, so there was no evidence of macroglossia. Furthermore, taking full advantage of the exceptionally favorable fetal position and the mother's minimal maternal abdominal adipose tissue, a detailed study was performed both in 2D and using Doppler ultrasound on the heart. Here you can observe the 4-chamber view with the left-sided cardiac section, which appeared normal, and with the use of color Doppler, a regular ventricular filling with a normal cross. The nasal bone and structure are clearly present, and even from this scan, you can see that there is no protrusion of the tongue, so there is no macroglossia. The rest of the abdominal anatomy was also carefully evaluated. Here you can see the evaluation of the longitudinal length of the liver, which was found to be well within the expected normal limits, and the stomach was in its anatomically correct and proper position. The ductus venosus was also carefully studied and found to be present. Both kidneys were observed in their normal positions. Here you can observe the right kidney and then subsequently the left one as well. The abdominal wall defect, the omphalocele, was evaluated multiple times, including in transverse scans, in order to confirm its anatomical location, and also the herniated content, which was confirmed to consist exclusively of small intestine. Here you can also observe the findings with great clarity in a scan obtained transvaginally. Therefore, although we were highly optimistic and encouraged with the patient, we still recommended a formal genetic consultation in order to thoroughly investigate and rule out any potential association with genetic or syndromic conditions, as well as a specialized pediatric surgical consultation to comprehensively establish and plan the postnatal surgical follow-up for this fetus. And thank you very much for your kind attention.